Warm welcome to this masterclass on challenges in the long-term management of psoriatic arthritis. Joining us today is Dr. Samir Abu Ajmi, consultant rheumatologist at Prince Mohammed bin Abdulaziz Hospital, Al Madinah Munawwara, Saudi Arabia. In today's masterclass, Dr. Samir will discuss challenges in the long-term management of psoriatic arthritis.
My name is Samir Abu Ajmi. I'm a rheumatology consultant working in Prince Mohammed bin Abdulaziz Hospital in Al Madinah Munawwara, Saudi Arabia. I hold the German board for internal medicine and rheumatology, also the Jordanian board for internal medicine and rheumatology. I am a member of the Saudi Society for Rheumatology and a member of the German Society for Rheumatology. I'm practicing now as a consultant since more than 12 years. I practiced in Jordan and since more than 12 years also practicing here in Saudi Arabia. Well, in the past we had limitations, but now I think with these new drugs we have many options. In the past, yes, we had only anti-TNF alpha, but now we have more options. And there are some drugs that we use in rheumatoid arthritis, but we do not use in psoriatic arthritis, like for example, tocilizumab, anti-interleukin 6, and rituximab, anti-interleukin 20. But the patients are now fortunate because we have a lot of new drugs and new things that we can offer them. So we can say now it's much better than the previous years. We have the variety of anti-TNF alpha and interleukin 17 and 23 antagonists and the JAK inhibitors. I think it's good for the patients. It's much better than previous. Yeah, we have this issue of compliance. Many patients, when they get better, they stop the medication, then they flare again. And many patients, they get tired from taking these medications. So on long term, what I do with my patients, I try to relieve them somehow from the treatment in a way that, for example, I'll give you an example. For example, if I'm giving someone infliximab every 8 weeks, then I start offering him to take it every 9 weeks, and then after a while every 10 weeks. So it will be a little bit relief. And also for example, adalimumab, if I'm giving the patient every 2 weeks, then when I see that he's in remission for a couple of years, 3 years, and he's tired of the injection, I think, okay, don't stop. Let's do it every 3 weeks or every 4 weeks. Yeah, this is what I do sometimes. But unfortunately, yes, we have this issue. We try to explain to the patients, this is important to you. This is also that the disease might also cause cardiovascular risk because it's a chronic inflammation. You have more risk for cardiovascular disease than people without chronic inflammations, chronic arthritis. Yeah, we explain this to the patient. We encourage the patient to continue on the drugs. Yeah, but we have, of course, cases where patients let go of the medication, then comes after a couple of months or 3 months with a bad flare of the disease, and we start from zero again. Yeah, this is what we face, actually. Yeah. These drug holidays, I decide only if the patient is in long-term remission. But the patient that's not in remission, I don't do any holidays. No, maybe I add things, but not drug holidays. This what I do when the patient is in a long term, 2 years, let's say 2 years, good in good status, good in remission. Then yes, we start to make a longer period of injections. Yeah, this is what I do. Well, my message to the patients that it's very important to take your medications regularly and to follow the doctor's advice, because this disease not only might distract your joints and impair your life, but it also can affect your heart, your vessels. It has a really cardiovascular risk on your body. So it's better to comply and do whatever your doctor says. And for the doctors, for the juniors, I advise to examine the patient thoroughly. These patients come to us usually from dermatology. So when you examine the patient thoroughly, you might see something. For example, I had a patient without any problem sent to me from dermatology. And when I examined him thoroughly, he had sausage fingers, dactylitis, swollen, and he didn't even complain. But when I saw them, I really diagnosed him immediately as psoriatic arthritis. We started the treatment, and the patient improved very well. And so first thing, examine the patient thoroughly. And the second thing, don't be tired with the repeated flares, because these patients really flare much more often than rheumatoid arthritis. We need to be also patient with this patient, and your follow-up also should be accurate in regard of the patient's complaint, your lab works, your physical examination, and the X-rays or MRIs that we do. Yeah, this is in general my advice, and I think now almost many doctors do this, and this is wonderful at this time, because all the doctors are having more lectures and more informations, and they are doing a good job.
Thank you, Dr. Samir, for your valuable insights.